Bismillahirrahmanirrahim. Dear students, I am Dr. Jamil from the Physiology department, and this lecture is in continuation with the renal physiology. And we have studied the different physiological aspects, or you can say anatomical physiology, in the previous lecture. And in this lecture, we are trying to understand the basic physiology of the GFR, that is the glomerular filtration rate. In this diagram, although all of you are advised not to follow this red dot, just follow my cursor having a circular reddish one circle around it, and don't follow this red dot. So in this diagram we are trying to fit the nephron in the kidney. Here you can see the yellowish color, or this color outer one where my cursor is moving, this is the cortex, and inner one is your medullary area, and this is obviously your pelvis. And here you can see that this is a glomerulus where my cursor is. This is a glomerulus. Don't follow the red dot, just follow my the cursor arrow. This is the glomerulus, and we have got the Bowman capsule over here, and this is the proximal convoluted tubule. So from this diagram you can well understand that all the glomeruli, all the proximal convoluted tubule, the PCTs, they are present in the cortex. Then the loop of Henle is present in the medullary area. Then we have got the thick portion, and then distal convoluted tubule is also present in the cortex. And then some collecting duct is divided into two parts. The some of it is present in the cortex, which is known as the cortical collecting duct, and some of it is present in the medullary area, which is known as the medullary collecting duct. Now you should have an idea about that where the anatomical position of the nephron is present through this diagram. Now, what are the different functions of the kidney? And we have got different chapters regarding these functions. First of all, excretion of the metabolic waste products and the foreign chemicals. One of the major products is the urea, which is removed by your kidney, and other waste products are also removed by your body, from your body, through the urine. So we have got a special chapter for this, how the urea is removed from your body. Then the regulation of water and electrolyte balance is again a very important, and we are concerned with the ADH over here. And electrolyte means sodium, potassium, bicarb, and chloride. Whenever you are using the word electrolyte, that means sodium, potassium, bicarb, and the chloride. In the clinical practice, you usually write serum electrolytes. You write down you prescribe a test for the patient that please do a serum electrolyte. Serum electrolyte means your lab will provide you how much sodium is present in your plasma, how much present your potassium, chloride, and bicarb. So kidney is very important function to regulate, and we have got the different areas we will study in detail, particularly the sodium and the potassium, bicarb. We have got a separate chapter for this one. Then the regulation of the body fluids, osmolarity, and electrolytes concentration. Again, we have got a chapter for this purpose. Then regulation of arterial pressure. Keep in mind that the kidney has got a very close contact with the blood pressure. Actually, the most common cause of renal failure in our country, not only in our country but throughout the world, is the diabetes mellitus. Diabetes is the major cause of renal failure or end-stage renal disease. The second most common cause is the hypertension, the raised blood pressure, hypertension. How kidney is performing all these things, how the kidney is related with this blood pressure, soon we will see in the coming lectures. Then the regulation of acid-base balance. This chapter is, again, we have got a separate chapter for this purpose, and here we are concerned with the hydrogen ion. Hydrogen ion, when we say the word acid, that means hydrogen ion, and actually we will study the hydrogen ion in detail in the chapter of the acid-base balance. Then the metabolic functions of the kidney. What are those? That the formation of ammonia. We will study this in the chapter of the acid-base balance, as how the ammonia is formed by the kidneys. Then the gluconeogenesis, that means formation of glucose other than carbohydrates. That is, this function also performed by the kidney, but only during starvation. And then Insulin degradation, that is the 20% of the insulin which is produced by your pancreas beta cells is degraded through the kidneys. You know from the your physiology, your endocrine lectures that once the insulin is released and it enters into the liver through the portal circulation, 50% is degraded there immediately. Then 50% is available for its function. Then 20% is degraded in the kidneys. That's the reason that when there is a kidney failure, this degradation is not there and insulin remains in your body and the patient insulin requirements are reduced and patient is going to misinterpret this thing that my sugar is going to be normal or I have to reduce the insulin dosage. Actually that patient is in the renal failure. Then production of the renin, a very important concern with the vasoconstriction, with the sodium retention. Then erythropoietin is concerned with the production of the RBCs. Then the prostaglandins, which are concerned with the different sort of the pains. And the active vitamin D3, this is very important. The active vitamin D3. Actually, vitamin D1 is produced in your skin, D2 is produced in your liver, and D3 is produced in your kidney. This is the reason that whenever there is a kidney damage, the vitamin D is not there, vitamin D3 is not there. That's why the calcium is not reabsorbed properly from your intestine, leading to hypoglycemia. And the patient has got the multiple fractures, pathological fracture in the case of renal disease. Then the cyclic AMP. All these are the metabolic functions of the kidney we will see in detail in the coming lectures. Then here's a slide that is the difference between the cortical and juxtamedullary nephrons. I have told you in the previous lecture that there are two types of the nephrons. One are known the cortical nephrons, these are those nephrons which their glomerular Bowman capsule lies in the top of their cortical area. While the juxta means near, juxtamedullary, that those glomeruli which are lying near to the medulla are at the border of the medullary cortical junction. So here the slide, you see the location, the cortical nephron, the outer part of the cortex, juxtamedullary, the inner part of the cortex next to the medulla, or in simple words, they are very close to the medulla, although they are in the cortex, but they are close to the medulla or near to the medulla. Then their glomerular, size of the glomeruli. In the cortical nephron, they are small in size, while in the juxtamedullary, they are big in size. Then loop of Henle is short next to the outer cortex, while the longer in the juxtamedullary, the loop of Henle is quite long and go quite deep into the medulla. Juxtamedullary nephrons. Then there is a diameter of the afferent arteriole and efferent arteriole. Afferent arteriole is more than the efferent. This don't need to remember these 2 points, the diameter one. Then efferent arteriole. In the efferent arteriole, they perform the peritubular. Actually, efferent arteriole is going to convert into the peritubular capillary network. While in the juxtamedullary nephron, the efferent arteriole is going to join another vessel which is known as a vasa recta. Actually, the vasa recta is the continuation of the efferent arteriole in case of juxtamedullary nephrons. Then sympathetic innervation is quite rich in the cortical nephron, while it's very poor in the juxtamedullary nephron. Then the concentration of renin is high in the cortical nephron, while it's nothing in the juxtamedullary nephron. Then the ratio, that means amount, if you are going to count how much they are. So the cortical nephrons, they are approximately 90% in number, while the remaining 10% are juxtamedullary nephron. Then cortical nephrons, they perform the function of reabsorption, the secretion, while the juxtamedullary nephrons, they are very important for the production of the concentrated and the dilute urine. So here, if the question is a university question, what is the difference between the cortical and juxtamedullary nephron, you can write down in this way. Now, we are starting the main topic now, that's the glomerular filtration rate. And inshallah, we will study in different ways, in different, you can say under the different headings. One of very important, how we are going to define it, the definition of the GFR. Then we will see the structure of the filtration membrane. Actually, the filtration membrane is very important. We will see soon all the structure of this glomerular basement membrane. Then the Starling forces, that means the forces which are required to cause the filtration. Then autoregulation of GFR is very important, university question, autoregulation of GFR. Measurement of the GFR. This topic we will study in the next chapter, how you can measure the GFR. We will see in the next chapter. The factors affecting the GFR we will see in the same lecture. Then importance of the GFR as a lab test. We are doing this GFR in our nearby hospital, that is Pinham Hospital. We are doing this lab test by the radioactive isotopes. So let's start the GFR. Now, this is a definition. GFR is the rate at which plasma filters through glomerular capillaries. Glomerular capillary means filtration slit membrane and forms a filtrate in the Bowman capsule per unit time. That means I will going back to the another diagram from where you can well understand things, that how much plasma is filtered out per unit time from this glomerular capillaries into the Bowman capsule. This is the GFR per unit time, and this is approximately 125. Back to that one. Normal GFR in adult is 125 ml per minute or 180 liter per day. I am going to emphasize on this word 180 liter per day, because this, if you have 1 liter bottle, you have to fill this 180 liter bottles per day, and then you have to empty them. Your normal urine production is just 1.5 liter. So if you filter out 180 liter, I am going back to the same diagram again. If you filter out 180 liter per day daily from here, and you can excrete only 1.5 liter, so where is going your remaining 178.5 liter? That 178.5 liter is some of which is going to be reabsorbed and some of them going to be secreted here. So filtration GFR is 125 ml per minute and 180 liter, a huge amount, 180 liter is filtered out, and out of 180 liter remaining, you have to pass just 1.5 liter, remaining 178.5 is going to be reabsorbed. So you can well understand by an example that if you are provided with a 1 liter bottle, you have 80 bottles in your house and you have to fill it daily, and then you have to empty it daily. This is the function of the kidney. So 180 liter word, you can conceive the idea how much huge function is performed by your kidneys. So normal GFR in adult is 125 ml per minute or 180 liter per day. Now what is meant by the filtration fraction? Filtration fraction, actually what happens? Once the things they are moved toward the glomeruli, suppose you are going to provide 100 ml plasma to the glomerulus. All of the 100 ml is not going to be filtered out. 20% is just filtered out. That means 20 ml is filtered out, and 80 ml will not be filtered and move as it is through the efferent arteriole onward. So filtration fraction can mathematically GFR divided by the renal plasma flow. It is a fraction of renal plasma flow that is filtered out and is 20% of the renal plasma flow. That means filtration fraction means how much is going to be filtered out. That is the filtered fraction. Then GFR can be expressed as according to the following formula. That formula is GFR is equal to the Kf multiplied by the net filtration pressure. And then what is meant by this filtration coefficient? Kf is the filtration coefficient. Again, the filtration coefficient can be expressed by a formula, that is the GFR divided by the net filtration pressure. Now your GFR is 125 and your net filtration pressure is 10. We will see soon that how, from where we have got this figure of the 10. This is very important. That all the filtration is going to occur because of the pressure difference of the 10 when we will see the Starling forces. And all the reabsorption is also because of the pressure difference of the just 10 millimeter of mercury. So if you divide GFR by the 10, that is the net filtration pressure, you got the 12.5 ml per minute per millimeter mercury filtration pressure. This is your Kf, or the filtration coefficient. And this, if you express this filtration coefficient On the mass of the kidney, that is per 100 gram of the kidney, it is 4.2 ml per minute per millimeter of mercury per 100 gram of the kidney. This is very important figure just to realize that how much filtration fraction, or you can say Kf, how much permeability of the kidney is there, how much Kf is there. That is, for the kidney it is 4.2 ml per minute per millimeter of mercury per 100 gram of the kidney. It is 400 times more than the Kf of all body capillary bed, which is just 0.01, leading to the rapid filtration in kidney. That means throughout your body you have got just 0.01 filtration fraction, your filtration coefficient, while your kidney has got 4.2 ml per minute per millimeter of mercury per gram of the kidney. So that means how much rapid is the filtration in the kidney. Actually, the problem is this is not, blood flow is very high to the kidney. Filtration fractions, rapid filtration is in the kidney. The blood flow, you can, when you have studied in the previous lecture, that your kidney is going to receive the approximately 1 liter or 1100 ml of the blood, the 22% of the cardiac output. Actually, it is not the metabolic requirement of the kidney. It is the requirement of the blood to go again and again to the kidney just to get rid of the waste products. That's why kidney have to receive. Kidney is not willing for all these things. Kidney is just for, it is the blood supply of the kidney is not for its metabolic requirements. Blood supply of the kidney is the requirement of the blood to move again and again to the kidney just to get rid of the waste products. Then, what is the function of the very important thing, glomerular basement membrane? Before in going to the details of those things, I would like to move to a slide. Here you can see this one. Thus you will see this is a, you are going to zoom it now. This is the basement membrane. This is the blood flowing. On this side, blood is moving. And this is the endothelium, the blood vessel. And this is your basement membrane. And from here you have got the podocytes. We will see in detail how much, what is podocyte, what is meant by this. Again, this is going to zoom it now. Now you can well understand this. This is the blood, this is your capillary, glomerular capillaries, and these are the endothelium. These are the fenestrations between the endothelium, spaces between the endothelium. And we have got the basement membrane. We will see the details of this basement membrane. And on the other side, we have got the podocytes. From here, we have got the podocytes. Now, look at this diagram. This is the cut section of this one. This is your glomerular capillary, the afferent arterioles, the efferent arterioles, the glomerular capillary, and we have got the cut section over here. You can see this is the reddish one is your capillary from where the blood is moving, the afferent arteriole, the glomerular capillary bed. And in the glomerular capillaries, you have got this greenish area. This is your endothelial cells, and we have got fenestration. You have seen, you can easily see that there is a spaces between the endothelial cells. These are not the fenestrations, and this is the light green color is your basement membrane. And if you move, this is the basement membrane. This actually this green area, this endothelium, and this is from the endothelial surface. This is from your capillary surfaces. So endothelium, fenestration, basement membrane. We will see in detail the basement membrane. On the other side, if you move from the Bowman capsule, if you see from the Bowman capsule, this is your parietal layer of the Bowman capsule, and this is the visceral layer of the Bowman capsule. The visceral layer of the Bowman capsule, which has got the epithelium, these epithelium cells, they are large in size, and they send, you see the finger-like extension. These are, follow my cursor, the arrow. These finger-like extensions, they are sending these finger-like extensions, and there are spaces between these finger-like extensions. These are the spaces between them. These are spaces between them. These are known as slit membrane. These are the glomerular filtrate is coming here. So this big cell is known as the podocyte. This big cell is the podocyte, and this is the fenestrations of the endothelium. And you will see in the next diagram. I'm going to the next diagram. Later on, we will soon we will see in detail all these things. Here in this diagram, This is your glomerular capillary. This is your glomerular capillaries. You can see this is the portion, follow my cursor, arrow on. This is this area. This is the parietal layer of the Bowman capsule. This is the parietal layer of the Bowman capsule. This is the bluish one, the parietal layer of the Bowman capsule. This one is inside. This is the visceral layer, which is going to you are going to surround your capillaries, glomerular capillaries, and this is that layer. In these, the epithelium is going to be enlarged themselves, and they are known as the podocytes. There's my cursor arrow is moving around the podocyte. This is again a podocyte. This is again a podocytes. So these podocytes, they are sending the extension which are known as the pedicles. These are the pedicles are sending by the podocytes. Actually, the podocytes, they are nothing but the epithelium of the visceral layer which is going to catch the going to surround your glomerular capillaries. This is your parietal layer, this is your visceral layer. Visceral layer has got the podocytes. Podocytes send the extensions which are known as the pedicles, and between these pedicles you have got the slit membranes. Between these you have got the spaces between them. I'm moving back to your previous diagram. This is the so these are the podocytes, and these podocytes, they are sending finger-like extension which are known as the pedicles, and there are the slit gaps between them. This is one. So this is your visceral layer. Sorry, this is your parietal layer. So the plasma has to be filtered out from this area. If you can follow my arrow, it is moving down. It's passing between the fenestration. It has to pass the basement membrane, then it has to pass into the slit areas, then it has to pass the podocyte, then it has to enter on this area, and from here it has to move into the blood vessels, oh sorry, into the nephron. If you move to the next diagram here, so after passing all these area, it has to enter into the Bowman capsule. This is the Bowman capsule, whole of this is the Bowman capsule, and your nephron is going to start from here, this area. So blood will move from here. From here it will enter, it will be filtered out through this. A 20% will move into this area and 80% will move into this area. Now filtration depends upon the first of all the structure of the basement membrane. The glomerular basement membrane, it contains three layers. The name given to them is lamina rara externa, lamina densa, lamina rara interna. There are different names given to them. And the externa, adjacent to the podocytes. This is a podocyte, the process made up of heparin. This rara externa is made up of heparin sulfate, and it's blocked by the charge. It's made up of heparin sulfate, and blocked by charge means actually what happens? Your basement membrane is negatively charged. This is negatively charged basement membrane. And the thing I want to emphasize is that the albumin is also negatively charged. So this albumin is, suppose here you have got an albumin molecule, and this now follow my this arrow. If albumin wants to move and it has to pass through the fenestration, then it has to cross this basement membrane. But this basement membrane is already negatively charged. So this negatively charged basement membrane is going to repel the albumin. This is the main cause that how the albumin is not allowed to pass through the basement membrane. But if this membrane become damaged due to the hypertension, due to the diabetes, or due to the Goodpasture syndrome, then albumin, or in the nephrotic syndrome, very important name, nephrotic syndrome, for you people. We will see in the coming lectures what is meant by the nephrotic syndrome, how we will define it, how it is produced, nephrotic syndrome, which is leading to the edema of your body. Nephrotic syndrome, very common in our country. So this albumin has to cross fenestration. Actually the size of the fenestration is big than the size of the albumin, but still the albumin is not allowed because of the negative charge of the displacement membrane. Here at the top I have written this: filtration depends upon the size and charge in the particle to be filtered out. Should be less than, actually this filtration, these fenestrations are the 8 nanometer. So the anything which has to move, any molecule which has to pass through this, it should be less than 8, and it should have no negative charge. Although the albumin, the diameter of albumin is 6 nanometer, that means less than the fenestration. It can cross the fenestration, but the second barrier, the negatively charged basement membrane, will not allow the passage of this albumin molecule from here into this Bowman capsule. So the glomerular basement membrane is made up of the heparan sulfate, the external layer, then the central portion, lamina densa. It is made up of, it is dark central zone, is made up of 4 collagen and laminin that is blocked by the size. Actually, it's quite difficult for me to make you understand through this audio only. If board work will allow, I will make you understand how this blockage is going to occur. Then the lamina rara interna adjacent to the endothelium is again heparan sulfate. This is heparan sulfate. Is blocked by the charge. Heparan sulfate is actually negatively charged. That's why negative charge is going to repel the negative charge of the albumin. Then what is the clinical importance of this glomerular basement membrane? I have told you that this glomerular basement membrane is going to damage in different diseases, and mostly when there is antibody formation occurs against it, then it's going to be damaged. A very important disease is Goodpasture syndrome, in which your lungs are also involved. So the capillaries become inflamed as a result of damage to the basement membrane by the antibodies to the type 4 collagen. Actually, this is a disease in which your kidneys and lungs, they are both involved. This is an autoimmune type of the disease. Then the nephrotic syndrome. We will see in detail regarding the nephrotic syndrome. Actually, the patient suffering from the nephrotic syndrome usually have got the edematous face, edema on the leg, and it has got the hyperlipidemia. That means the lipid profile is quite disturbed. And all these things are due to the proteinuria. That means proteins are passed into the urine because the negative charge is not there on the basement membrane. And whenever I'm using the word proteinuria, that means albuminuria. Albumin is of smaller size. We are not concerned with the globulins. Globulins are not concerned here. We are concerned with albumin. So proteinuria means albumin is passing through your urine. When the albumin is passed through your urine, that means what happens? Inside your body, there will be a reduced amount of albumin. That will be known as a hypoalbuminemia. And keep in mind the word, my sentence, that sodium and the albumin, they keep the water with them. Whenever your albumin will be remain in the vessel, it will try to retain the water with it. Whenever the sodium in your body, it will try to retain the water with it. So the sodium and the albumin, they always try to retain the water with them. So once the protein is removed from your body, actually now again, remember it, that protein albumin is formed by your liver. So if the liver is damaged, that is, if the liver is damaged, again there may be the hypoalbuminemia. And when there is hypoalbuminemia, that means albumin is less in your body, so it cannot retain the water within the vessel. So water will leave out the vessel and accumulate in the interstitial tissue spaces, leading to the edema. Actually, whenever I am using the word edema, that is the accumulation of the fluid in the interstitial tissue spaces. We will see in detail how the edema is going to be formed, what are the safety factors against the edema. We will see in detail in the coming lectures. So hypoalbuminemia, it will lead to the edema. Edema means accumulation of the fluid in the interstitial tissue spaces, and there is a hyperlipidemia is also there. When we will study the nephrotic syndrome, we will see the details of all these things. Then the diabetic glomerulosclerosis. Sclerosis means tides. Glomerulosclerosis is the thickening of the basement membrane, which can become up to 4 to 5 times thicker than the normal. This is what happens in diabetes. When we will see diabetes in relation to the kidney, how the diabetes is leading to renal failure, then we will see all these things. Now another diagram regarding the basement membrane and the endothelial cells and the podocytes. You can well understand this is the endothelial cells, the reddish one, and here is the light blue, light purple, dark purple. This is your basement membrane, and then you have got the podocyte, then you have got slit membranes between these two. So these all is concerned with your basement membrane. Again, a very simple diagram for your basement membrane. That is, this is the endothelial cell. Reddish one is the endothelial cells, and arrow is showing that the plasma is moving from this side to this side. So this is a basement membrane, and these are the podocytes. This bluish color and the greenish, these are the podocytes. There we have got the filtration slits between them, and these are the podocytes. So all this diagram just to conceive an idea regarding your basement membrane. Thank you very much, and we will see in the next coming lecture what are the details of what are the stalling forces, the other thing. Thank you very much. Thank you.